Right. I did ask that my slideshow be put up for me, please. Would you be able to do that for me, please?
Yes.
Thank you so much. We have power outages here in South Africa, and I didn't want one to happen in the middle of my presentation and for us all to be scrabbling to find the PowerPoints. So if you could just open the PowerPoint, please.
Can you see the screen, ma'am?
I can see just the first. Can everybody see the PowerPoint? Okay.
Yes, ma'am.
So thank you. Sorry about this. So just a little bit of background. I've been in the field of palliative care for 33 years and working with children for most of that time. From very early on, when I started working with the new hospice in Bloemfontein, where I live. And in those days, we didn't have the internet, so we didn't have Google. We didn't have the communications that we have now. And it really was a bit of a business of patching together training programs, reading a little bit from Sister Frances Dominica. And over these years, there has been tremendous growth and development, not only in palliative care. I was a founding trustee of the Worldwide Hospice Palliative Care Alliance, so I've been in the global field for quite a long time, but especially in palliative care for children. And so what we're going to do today, because I've been asked to give a global perspective, we'll look at where we are with palliative care for children. We'll look at the challenges that we're having to face and how we're having to do it. And we're going to look at just a few areas, because we have a limited amount of time, of where there has been new developments in the field of palliative care for children. If you look at this map here, it is the latest map from the International Children's Palliative Care Network. What you see is in the darkest areas is where there is integration of children's palliative care into the health system, at least in some level. It might be policy level, it might be hopefully funding, it might be as part of the health system as such. In the white areas, there is no known provision of children's palliative care. So if we look here at your country and my country, which is South Africa, it actually looks pretty good, because we seem to be dark. We're not the darkest green, which is difficult to see, but we seem to have some good development. And you have got some brilliant, brilliant children's palliative care programs. I worked with Professor Marianne Mukadeen for 5 years in a development project and got to meet many of the people working in the field from 2010 to 2015. And I've kept up my contacts in India. So this looks good. This is research we did with UNICEF. And we looked basically are there good programs? Is there good education? Is the government even just maybe saying, okay, we think it's a good thing? But let's look at the next slide. And this is the next slide is a more recent research which was done via the University of Glasgow with leading names in the field of palliative care, Dr. Stephen Connor, Dr. Carlos Centino, Dr. David Clark, all involved in this particular evaluation. And they interviewed experts in the different countries. And you'll see that both your country and my country don't seem to be doing that well. And so there's a lot of discussion around the accuracy, but actually there is no accuracy, because the world is changing all the time. As we are doing the research, things are changing in countries. And of course, if we're looking, and we're going to look a bit later, at the impact of humanitarian crises on our field, then you will see that what we have here is just an idea. And this picture shows that you've got excellent programs around India, but you haven't got a comprehensive network that is working with collaboration, with communication, with inter-program referrals. So the next slide, please. The most common conditions that are seen worldwide, and this is from research by Dr. Stephen Connor, first of all is HIV. Why HIV? If you look at where most of the children are who receive palliative care, it's in Africa and in Southeast Asia. That accounts for over 70% of the children in the world. And of course, we know in Africa, HIV is still rife despite antiretrovirals. And in Southeast Asia, you still have large numbers of children who are HIV positive. So HIV, but after that, it's conditions around birth. So premature birth, birth injuries, and then if we look at congenital anomalies as well, most of which appear around the birth period, you can see this period of birth is such a dangerous time for children. And this is why care of pregnant mothers, care of women before pregnancy, and care during the pregnancy and at birth and after the birth are just so important in palliative care. And that's why we have got to include our midwives in the palliative care that we give to children. Then after that, injuries, and if you look at cancer, which has tremendous support across the world, we have Childhood Cancer International, we have World Child Cancer, we have the UICC for cancer. It's only 4% in comparison to the rest of the conditions. And what does this say to us? So the next slide, please. Is that there needs to be within children's palliative care, and there certainly is, an increase in specialization. In the beginning, we were looking after children from birth till around about 2021, and we had pretty much the same curriculum for everybody. And of course, there's a world of difference between the neonate and the teenager, and in fact, with every age. So there's definitely specialization developing in neonatal, perinatal palliative care, in adolescent care, because we know that that is a group all on its own, and young people, and then disease specific. And here we think of cancer and HIV, and then on disability, not only physical disability, but also intellectual disability as well. Next slide, please. And again, when we look at these maps, you'll see 98% of children who need palliative care are in low and middle income countries, whereas nearly all the resources for advanced palliative care or specialized palliative care are in the high income countries, where only about 2% of the children who need palliative care live. So we're looking at vast disparities, not only between countries and between regions, but actually within countries as well. And I think we know there are a number of different issues which affect this. So next slide, please. So what I did is I went to the global leaders. We had met together in May in Rome, and I asked what their ideas were about the new developments. And what they really said was the new developments are based on the old. Because on the old, we had these individual programs that were developing and were expert programs. And it's building on these, like the EPIC Pediatrics, which is a wonderful training course which you've had, and you have trainers in India itself, which came from the US, but is being adapted for the different regions as well. It's increasing access to education, but it's not enough to do an online course. We need practicals, we need mentorship to do this as well. It's encouraging innovation, and this is so important. We have to keep innovating as the world changes. Just as we changed from 30 years ago to where we are now, we have to keep on doing, and that's the challenge for you. And especially the importance of technology. The more we use and the better we use technology, the more people that we can reach. And we have to be able to adapt. They say the best soft skill we all need is adaptation. Next slide, please. And we need to listen to the voice of the child. And this to me is the best definition of palliative care for children, which comes from Matty Stepanek, who was the fourth child in his family to live and die with a rare genetic condition. He said palliative care for children is to help them live well. And then when the time is there, to let them die gently. And I think that's a pretty good definition of palliative care for all of us. He was a poet, and he was a peacemaker, and he was a philosopher who played. And he wrote, before he died at the age of 12, he had 3 books of poetry that had been published. He was friends with Oprah, friends with Jimmy Carter, and he was a tremendous voice. We need to listen to these children. They know better than anyone what is happening to them and what they need. Next slide, please. And so what we're seeing and what we discussed in Rome is there's an increased need, and there really is a movement for collaboration. Because unless we all work together, unless we communicate better, unless we share our resources from low-income countries and high-income countries, and unless we work with other groups, and I'm going to give you an example of that and how effective it is, we will not be able to get palliative care to the world's children, to that 21 million children who need palliative care. Next slide, please. So a tremendous new development is PalliaPed, which is the only international pediatric palliative care journal. The editor is Dr. Franco Benini from Italy, and I'm honored to be on the editorial board along with many of my colleagues. And this is so we can share research and information. And I really encourage you to read the journal, it's online, and also to contribute towards us. We need to learn from each other. Next slide, please. And then what is happening in the world? 20% of the world is experiencing humanitarian crisis, a huge number. And so, of course, this is impacting on the work that we do and on the children who need palliative care within those humanitarian areas. And because I have worked a lot in Ukraine, I'm very involved with Ukraine, I'm going to use an example just now of how we work together and how we improve palliative care for children through collaboration, through cross-border collaboration, through sharing resources and sharing what we know. So next slide, please. So what does this mean for children's palliative care? Well, need for neonatal palliative care increases. We need to increase access for children to pain medication, because in a humanitarian crisis, all of these chains of supply are interrupted. They're interrupted by the crisis itself. They're interrupted in a war situation by the destruction of facilities and resources, and by the breakdown in communication transits. And of course, we need to make sure that the knowledge that we have crosses all of those barriers. So next slide, please. I've talked about the increased need for neonatal palliative care, and what we see in Ukraine is 50% of all births are premature or complicated. That's huge. It says we need neonatal palliative care, which was only really beginning, and there is still a little bit being provided in Ukraine. Next slide, please. Okay. So this global collaboration to support palliative care wherever it is started with PalChase, which is the Palliative Care Global Group for Humanitarian Emergencies. We now have a cross-border coalition that is working together to support children in Ukraine. And we have a very good e-learning course that was a collaboration between the RCPM and PalChase, which is open access and which you are free to do, and I encourage you to do, because humanitarian crises affect all of us. So next slide, please. This is just a charter that we brought out to say how we stand together as a global group. And we say to our friends and our colleagues in the humanitarian areas, you are not alone. We stand with you. We will not forget you, because one day it could be us. So the next slide, please. So the Safer Ukraine Collaborative was started by some Jude Global in the US, and they worked with groups like SIOP, World Child Cancer, Cancer International, groups in Poland, and then they worked with a center in Lviv in Ukraine, and with the Tabletotchki Foundation, which is a foundation that looks after children with cancer. And their main focus was on taking children who needed treatment and who had a chance on survival out of Ukraine and sending them to a variety of different countries, mainly in Europe, but some, of course, went to places like America and to Canada as well. So that's how the collaboration started, and it was incredibly effective. I had a child referred to me, and within 2 hours, the organization to get that child out of a basement hospital in Kiev, in a specially equipped ambulance, because the child was on ventilation, into a hospital in Germany had all been planned. So it was very effective. Next slide, please. And this just shows you how these children came out of Ukraine to all these different countries. And now we are working, because some children, as they reach the end of life, want to go home, and the families want to go home. So now it's getting them back across the border and mapping where we can send them to get some level of palliative care. And that is a collaborative that I'm working in at the moment. And I think this is a model for future humanitarian crises. If we really believe our children should have palliative care, we're going to have to work like this. Next slide, please. We have to increase the use of technology, and all the major UN agencies now have special departments which focus on developing innovation in using technology to reach more and more people. Without technology, we wouldn't be talking today. The next slide, please. Okay. And ethical issues. So there's more awareness of the ethical issues, especially around things like autonomy. Who decides for the child? All these big public cases that we've all heard about that's been in the news. And then, of course, things like withdrawing treatment and euthanasia. And I would encourage you, the ICPCN had an excellent webinar with Dr. Richard Hain, who's a leader in ethical issues in the world. And it's available on the ICPCN website. So please do go and listen to Richard Hain. He's a brilliant man, and he's a very experienced pediatric palliative care physician. Next slide, please. There's an increased realization of the value of spirituality in healthcare, and the George Washington Institute has a course coming up on interdisciplinary spiritual care education curriculum. It's a 2-day virtual course. There are bursaries available. So if you're interested in spiritual care, there is an aspect of it that covers children. I encourage you to contact GWISH and see if you can't get a bursary. Next slide, please. Of course, there are many resources that are available online, and these are increasing, and I would encourage you to make use of these resources as well. The next slide, please. And as we come up to World Hospice and Palliative Care Day, again, this is where we can collaborate, where we can share our advocacy voices, but most of all, use the voices of your children and families, because they are far more powerful than the greatest expert, the latest clinical expert in pediatric palliative care. And of course, the next slide is about the Children's Awareness Day. And that is hats on for children's palliative care. So if we could have the next slide, please. And that's on the 14th of October, where we all wear a hat to raise awareness. And please encourage your whole department to do it. It's a fun way, but it also has that serious aspect, because we're only reaching 5% of the children who need palliative care. And if wearing a hat helps us to reach one more, then we can all do that on that day. So the next slide, please. Because what we want to give these children is the simple miracle of as normal a life as we possibly can. And the only way we can do that is if we innovate, if we make use of technology, if we collaborate, and if we communicate. That's on the go at the moment. So help us through innovation from India, because India is a wonderful country for innovation. Help us to have new technology. Help us to innovate, to reach the other 95% of the children who need it. So thank you. Thank you for listening to me. And I'm very happy to answer any questions or discuss any aspect of the presentation.
Thank you so much, Joan. I'm sorry I can't switch on my video. Thank you so much for sharing your experience from around the world. And working in India for so many years, I think we still have a lot more to go in terms of pediatric palliative care. So can we go to the next presenter and take up the questions together so that he can do his presentation right now. Thank you, Joan. And Dr. Mohammed.
Yeah, hello. Hi. Hello, everyone. Am I audible?
Yes, please.
Yeah. So just a small introduction. I'm a pediatric palliative care physician based in Hyderabad. I work with Dr. Gayatri. Unfortunately, she couldn't make this meeting, so I am filling up for her. And I work in a tertiary care pediatric hospital and also in a tertiary care cancer center, where we do get a lot of children who are with palliative care needs. So going into my presentation, yeah. So the main theme is to tell what all services that are being provided in India right now. I don't have much information regarding various centers which are providing pediatric palliative care, to what extent they are working. But I know that Pallium India is doing a lot in getting pediatricians on board to do pediatric palliative care. And also there are centers in Delhi and there are centers in Vizag as well, which are doing some amount of pediatric palliative care. And slowly we are trying to be part of it so that we increase the capacity of pediatricians who are going to do pediatric palliative care as either full-time or part-time, so that we can help children better. So coming to my presentation, so according to WHO, the need for palliative care in India, if we see, is around 1% of the whole population. But this 1.46 million, this is according to a census which is taken from 2015. So this number has been increasing over a period of time, because like ma'am has said, that there is an increase in need for neonatal palliative care also. So in India, if you see, there are more and more children who are surviving post their neonatal period, who are born in premature phase of their life. So there's a lot of neonatal conditions also that are coming up, and which are going into infancy. So this number is ever growing. So our goal would be to increase the capacity as we go on. And if you see, you can see Bangladesh, Nepal, and Sri Lanka's numbers as well. And I think that these are also underestimated to an extent. Next slide, please. Coming to the childhood cancers, according to 2017 census, we are seeing around 50,000 newly diagnosed pediatric cancer cases in India. And when you see a 5-year survival of childhood cancers, in high-income countries, around 80 to 90% of children are crossing this 5-year survival rate. But in case of India, we are talking in general about places where there is good medical facilities. For example, the place where I work, as far as I know, it is somewhere around 20 to 25 only. So based on the services which are provided, this number varies. Next slide, please. So just going into, I'll not take much time regarding the criteria, categories where children are there where they need palliative care. So coming to the first category, next slide. So in this, we talk about life-threatening illnesses where curative treatment is available, but many a times it fails. For example, if a child is diagnosed with a cancer, for example, we had a child who was suffering from leukemia, who's like less than one, who was in infancy, and even though we tried giving him curative treatment, it did not help him. It did not give cure. So we had to go for palliative chemo, and we could only increase the lifespan for some time. And then we have conditions such as severe congenital or acquired heart diseases. For example, an obstructed TAPVC, that is transposition of great vessels also. So these illnesses where there is some amount of surgical option available, but many a times it might fail. And the next would be infections. So many children come with meningoencephalitic sequelae, which can lead to prolonged distress for the child. Also, this also includes severe malaria, where there is painful crisis, then there is multi-organ dysfunction. And also it includes multi-drug resistant TB as well. And in this category, we also have major thalassemia, thalassemia major, and sickle cell anemia as well. So all the children who are affected with illness, these children need to be supported at the earliest. Next slide, please. Coming to category 2, in this category, we have children who have illnesses where there is long period of treatment which aims to prolong life. So when they are diagnosed with this kind of condition, our major aim would be to increase the lifespan, but premature death is anticipated. So we need to make a crisis plan whenever a child is diagnosed with such conditions. For example, muscular dystrophies, which include Becker's muscular dystrophy or Duchenne's muscular dystrophy. They survive up to late adolescent to early adulthood. Then we have severe skin conditions such as epidermolysis bullosa, dystrophica, or junctional epidermolysis bullosa. So in these children, there is a lot of painful symptoms because the skin peels off easily. And these children also need to be seen with great care. Then we have severe immunodeficiencies such as severe combined immunodeficiencies or Wiskott-Aldrich syndrome, ataxia, telangiectasia, or X-linked agammaglobulinemia. All these conditions come under this category. And also we talk about severe respiratory failure. It can be because of having prematurity leading to severe respiratory failure, or it can also be because of any kind of disorders which lead to severe respiratory failure. Next slide. The next category would be of illnesses where there is a progressive course where treatment is palliative from diagnosis. For example, whenever we have a child who's diagnosed with trisomy 13, which is Patau syndrome, or we have a child with Edwards syndrome, trisomy 18, we know that these children will have a progressive deterioration in their general health. So these children are palliative from the time of diagnosis. There is no curative option. Or we have children where there is no curative treatment available. For example, a stage 4 cancer where there are multiple meds, or there are children with, we had one child who was like 1 month old, diagnosed with AML plus having Down syndrome. So in that child, the treatment was palliative from the start. We also include neurodegenerative conditions such as Rett syndrome and also metachromatic leukodystrophy as well. Next slide. This category includes children who are having severe disability, and this can lead to extreme vulnerability and lead to premature death as well. So many premature babies who cross their neonatal period and over infancy with severe cerebral palsy, these children have multiple issues such as feeding issues, breathing problems, or feeding issues. So all these things add up to the distress and can lead to complications as well. And we also include in this children with severe brain injuries because of meningitis or HIV, children with stroke, or children with severe brain malformations. So you must have heard about holoprosencephaly, lissencephaly. These are brain malformations where they have multiple issues such as seizures from the time of birth, or they can have severe developmental delays which progress over a period of time, and also severe hydrocephalus. It can be congenital or acquired. So these were regarding the categories in which palliative care divides children, and based on that we can make a plan. Next slide, please. So coming to pain in children. So pain in children, when we talk about pain, is the most common symptom that we see in children. And when we talk about pain, at least around 50 to 60% of children with cancer present with pain. And in advanced cancer, it goes up to 70 to 80%. And when we talk about pain, pain can be because of majorly can be divided into four categories. For example, pain can be because of the cancer per se. Pain can be because of the treatment process, for example, mucositis or any kind of thrombophlebitis. Or pain can be because of debilitation. Suppose a child is bedbound because of the illness. So it can also lead to painful symptoms. And finally, pain because of concurrent illnesses. For example, many a times we forget about calcium balance in the child, and the child might go into osteoporosis, can have pathological fractures. All these things come under pain. And not only cancer pain, we also need to think about pain in non-cancer conditions. Next slide, please. For example, in our practice, what we see is children suffer from severe painful crisis in case of sickle cell anemia. We have seen children with cystic fibrosis complain of pain. We have seen children with near daily pain in case of juvenile arthritis and also inflammatory bowel disease. And in case of infections as well. And in HIV/AIDS, we can see children who present to us with neuropathic painful conditions. And next slide, please. So not to go much into detail about pain in children, but the thing which I want to emphasize is you must all be knowing already that in children, we don't use a 3-step ladder. We only have 2-step ladder. So step 1 consists of non-opioids as well as adjuvants. Non-opioids includes paracetamol. Adjuvants include drugs such as gabapentin, tricyclic antidepressants, or NSAIDs. So all this, even dexamethasone, comes under adjuvants. Coming to step 3, we have strong opioids plus non-opioids along with that adjuvants. So when we talk about strong opioids, we are talking about morphine, fentanyl, methadone. So these are the strong opioids we use. There is no scope for usage of weak opioids in children. And tramadol is something which we totally avoid usage. Many a times in general practice where we see pediatricians using it, we tell them to be very cautious because it can lead to seizures because it decreases seizure threshold, as well as it can lead to respiratory depression. The metabolism is also not that good in case of children. Next slide. So these shows what all analgesics we use in India. This includes just non-opioids and opioids. We are not talking about adjuvants in this, but major adjuvants which we use in our practice is a tricyclic antidepressant such as tryptomar. We use sodium valproate as a pain neuropathic agent. We also use dexamethasone in case of whenever we are suspecting children with spinal cord compressions. So these all medications we use. One point I want to bring up is methadone is a very safe drug which can be used whenever morphine is not helping or we want to circumvent toxic effects of morphine. So we have had around 4 or 5 children who were started on methadone and it gave a wonderful response. So these children put on long-term methadone, and we have one child who was started at 11 months of age and is still on methadone now, and he is very comfortable and at home currently. Next slide. So just giving a brief about what we do in Hyderabad, what all services we provide in pediatric. palliative care. Next slide. So we started as a palliative care center in MNJ with an adult program, but over a period of time, it extended to pediatrics as well. And in 2007, we integrated pediatric palliative care into the cancer care at MNJ. Next slide. So the image which you just saw was leukemia ward, where we have a lot of children who are admitted for getting cancer treatment. And when we come to our program, we have around 40 to 50 children with cancer seen in our IP every day. Our services majorly start in the morning with a pain round, where we go to each and every child and ask whether they are in pain or not. Then we go to the ICUs, we cover the ICUs, and we come to the wards and look after the children over there. We also provide procedural pain relief in our wards, where we apply EMLAs to children whoever are getting procedures such as CSF analysis, or whenever there is a sample taken. So this is something which we do on a daily basis. We have started providing support groups recently. It's been a month with the help of newly appointed counselors. We also provide psychosocial support. We have a play therapy that happens every day, and we also support rehabilitation as well as provide bereavement support. Next slide. And then we have a program in Nilofer Hospital, which was started in July 2019, where after a lot of efforts of Dr. Gayatri and Dr. Spandana, we could start a department over there. It was run by Pain Relief and Palliative Care Society, with which I am associated as well. It has a dedicated pediatrician, 2 staff nurses, and a social worker currently. We also get services from our physiotherapist on once in a week basis. Next slide. So when we come to the patient profile, we have seen around 1,000 children and neonates, both included, with various life-limiting and life-threatening illnesses. And this number is growing over the period. We are seeing around 50 to 60 children with life-limiting illness. And this number is only the surface of it, because the hospital where we work is a tertiary care hospital. And many a times, apart from we getting referrals, we go and search for children who are diagnosed with life-limiting illness. So these are the conditions which we see in neonatal. We see a lot of children with severe HIE. We take up children with genetic syndromes. It can be Edwards, Patau, Chat. It also includes children with complex heart disease and renal disease. In case of pediatric, majorly what we have seen is children suffering from neurological conditions. We have children suffering from complex heart diseases and lung conditions such as interstitial lung disease and cystic fibrosis, and also hematological conditions such as aplastic anemia or major thalassemia. Also children with advanced HIV with opportunistic infections, MDR-TBs, and also severe chronic kidney diseases. Next slide. So the main theme of Pain Relief and Palliative Care Society is to provide continuum of care, so that care can be given to the child where they want to be also. So many a times children and parents are stuck in this loop of what to do next. Many a times they don't give this clear information that what the child is suffering from and what else can be done for the child. So palliative care team is able to provide or fill in that gap, where we are able to tell them what they can do or what kind of planning can be done for the child, so that the child lives better. Next slide. So this is our home care van. We also provide home care services. We have around 8 home care vans. We have 2 dedicated pediatric vans. Next slide. Our home care team is still in its nascent stage, to say the least, because we have a bit of higher turnover of nurses and majorly nurses. So the home care team is still trying to learn more and more about palliative care, so that they can provide best care for the children. So in this, we can see There's a child with osteosarcoma, he's bedbound and has been severe pain. But with the help of home care service, we are able to provide them care at their home itself. Next slide. And this is our a picture of our hospice. It is a 11-bedded hospice. We have increased the capacity from 8 to 11 now. And till date, we have had around 280 admissions. So we are slowly able to pick up and provide some care for the children with life-limiting illnesses. Next slide. And the 2 home care vans which we told, we have around 185 alive patients till date, and the number is ever increasing. So we are also planning to add 1 more van and provide good care for the children. Next slide. This is our palliative care team in MNJ. This is our home care team as well. Next slide. So when we talk about ensuring continuum of care, whenever we find or recognize children with palliative care needs, we enroll them, and if they are in home care within our home care limits, we enroll them under home care. And when they get discharged, we see that we follow them up. We see that we do phone calls based on priority. We prioritize patients such as low priority, medium, and high priority. And whenever there is any crisis or whenever there is any symptom that we feel might increase over a period of time, we ask them to come either to the hospital or to our hospice. So this whole loop continues. And we also have children who are admitted at other districts which are very far from our place, around 100, 200 kilometers. We have 33 centers which are also coordinated with our center, so that whenever a child is suffering from any kind of illness who wants to stay near the district, we make a plan so that they can go to the nearest palliative care center, and the doctor or the nurse do a video call. They try to assess the child, and they also educate the physicians over there, because many times we don't have a pediatricians at the district centers, and based on that we are able to provide some amount of quality of care so that the child amount of health care. Next slide. And like I said, it is an initiative that is taken along with the government of Telangana, where we are having 33 districts now which provide palliative care. Majorly it is adult palliative care that they are able to provide, but with the help of the nursing staff and the physicians here, we are also able to give some amount of pediatric palliative care at those centers. Next slide. So these are the various district-based palliatives. Includes a nurse, social worker, and a physician. They enroll patients and they go and make visits. Next slide.
Dr. Muhammad,
Yeah.
so we were not able to hear you. Can you repeat the slide again? Hello, Dr. Muhammad.
Yeah, this is the last slide. Hello.
Hello, sir. We were not able to hear you.
Yeah. Am I audible now?
Yes, sir. You are audible now.
Yeah. Thank you. So this is the last slide of what all training opportunities that are available in India. So there are DNB in palliative medicine, which is recently started at MNJ, but there are other centers such as Manipal. There is AIM Center, which has been there since quite some time. There is a center in Rajasthan, also in Gurgaon. So there are multiple centers where palliative care is provided. We provide 1-year fellowship course in our center, which is endorsed by RCPCH. A 1-year similar course is also provided at BJ Wadia, Mumbai. We also provide 1-month certificate course by MNJ on palliative care, which is a basic palliative care course. And we also provide a 1-month certificate course for pediatric as well. And currently we are conducting a course of ECHO 4.0 on pediatrics. And also we are providing a certificate course by IAP, which is going on currently. And there is a one-day workshop on communication skills that takes place. Next slide. I think this is the last slide. Yeah. And this IAP Con 2023, we are happy to tell that there is a workshop which we are conducting on pediatrics, where we are going to take up 2 workshops. In the morning, we have a workshop on pediatric palliative care for non-cancer conditions. And in the afternoon, we have serious illness conversation guide with children specific. So these are my presentation. Thank you.
Thank you so much, Dr. Mohammed, for bringing in an Indian perspective and experience from your institute in delivering pediatric palliative care. There is one question from Dr. Meenakshi. I always have this ethical confusion when speaking with older kids with advanced cancer about the prognosis and imminent death. The parents and the oncologists don't want to allude to it. The child knows or reads on the internet, but doesn't actually ask the palliative care team. So she's asking whether should she ask them if they want to know or wait for them to ask. I would like to hear from you, both of you, Joan and Dr. Mohammed. Like, what is your take on that?
What I've always found is that if a child knows and you provide that safe person for them to talk to, they will actually come to you. I think one of the problems we often have is that parents say to us, don't talk to the child about death or dying. And my answer is usually, well, I won't initiate the conversation, but if they talk to me, then I will acknowledge it. So especially with older children, I really find that if you are that safe person, you have a time to be quiet with them, that the question will come out. I don't know what others think, but I've always found that the children, even as young as 3, will come and talk to me about it. If you provide that person that they feel safe with to speak to.
I too agree, ma'am, with what you just said. When we provide that kind of safe environment, they do come and talk to us. And when we talk about older children, many a times what parents and oncologists misses, they are very intelligent and they have this internet and they have multiple sources from where they get information as well. And in the wards where we work, we have around 40-50 children admitted in the same ward, and there is no partition between each and every child. So when they see a child in severe pain or a child who's deteriorating in condition, they do have this thought that, okay, I think even I might deteriorate. They at times they wouldn't want to express it completely, but they have this fear in their hearts. And whenever we don't talk to them, we fall in this trap of total pain, and it becomes very tough for us to have a conversation. What we do in our practice is, with the help of play therapy or with just a simple communication or just having a friendly talk, many a times they do come and speak to us. What is happening with me? The oncologist is not saying anything to me. He's not getting the work done. So these are the kind of things which we hear. Many times children are very anxious to know what next treatment would be, what next procedure would be, because older children are much more forward in coming and asking us. And when we have this component of collusion between the family members and the child, it becomes very tough. So there was one child, I just want to share this experience where parents were talking, wasn't telling to the child anything. And this child simply put the phone in record mode and went to the other room. And when the parents spoke, she just came and heard the whole conversation. So children are very intelligent. They'll get the information in whatever way they want. But if the parents or physicians do have that conversation, it helps a lot in decreasing their distress, because they are putting their whole trust on us. to know more about their condition or to know how to overcome this. So it will be best if we can provide some information such as, or simply ask their perception. What do they feel is happening to their body? Which hospital do they think they are admitted? We at times just ask them, which hospital do you think you are admitted? They say that I'm admitted in a cancer hospital. So they do know that it is cancer. But at times we need to just explain them what cancer means furthermore. So it is best to have a conversation from our side rather than wait for them to speak to us. Many times it can just start with simple inquiry about what their perception of what is happening with them. So with that, I think it is an opening. So any other thoughts, any other experiences?
So I think essentially Dr. Meenakshi was asking, should she wait for them to come and ask her, or should she just, so I think from what you both are telling, maybe we can just start a conversation about what do they understand about what is happening to their body. So probably you're conveying that there's a safe space where you can come and ask questions. So maybe when few visits, the children may come and ask you like what is happening.
Yeah.
Wonderful. Thank you so much. Yes, Joan, please.
You can even just say something simple like, is there anything you'd like to ask me? Or is there anything you'd like to tell me? It's the way you do it. You know, the fact that you don't stand over them, you sit with them. You might be sitting and playing. And as you're playing, you might say, you know, is there anything you want to ask me? Is there anything that's worrying you? Just give them the opening, because so often that's what they're looking for. Is there, and as you said, play is so important because play relaxes them. It's a place where they have control and they feel safe to actually ask these questions.
Yeah,
and sometimes they'll just
wonderful.
tell you, yeah, they'll just say to you, I know I'm going to die. Or they will show you by saying, I want to go and say goodbye to somebody. Or will you give this to my best friend when I'm not here anymore? So you've just got to be open to those opportunities for the conversation.
Thank you both of you. That was wonderful. Asking simple questions like, you want to ask me something or you want to tell something, probably is the best way to get connected with the child. There is another question on dose of morphine and methadone to Dr. Mohammed. I think it's specifically on methadone. Do we need to do ECG before starting methadone as to look for QT prolongation?
So many a times we are, suppose if a child is admitted in hospice and we know that the child is end of life, we don't emphasize on doing a battery of tests such as doing electrolytes or ECG. But if ECG is available in your center, you can have a baseline ECG just to know what is the baseline, and you can start methadone. What we tell regarding methadone is go small and go slow. So you can simply start with a lower dose and slowly build it up. You can at times start it as a night dose, or you can start it as a BD dose and slowly increase it. But in our practice, majorly, whenever a child is admitted in hospice, and if we don't have the facility, we let go of doing the ECG. We see for the recent electrolytes, potassium levels, and start on methadone. But if you have in your center, it's always best to go for a baseline ECG. But for the sake of ECG, if it is getting delayed, don't wait to delay the dosage of methadone, because even a single dose of methadone, if it is started, it is helpful. Yes, the T half of methadone is long. It might take 5 to 7 days for its action to come in a full way. But still, if you have ECG, you can get it done. And if you don't have ECG, it doesn't make you not to start methadone, because we have started methadone. It is totally safe, provided you go small and slow. You slowly increase. And we have few children who have been on 35 mg of methadone 3 times a day also. And in them, we have checked ECG, and yeah, it is totally safe. You can use it. And regarding one more point about morphine, so whenever we start morphine, we start with the dose of 0.2 to 0.3 mg per kg per dose. But many a times, suppose if a child with, for example, 30 kgs comes to our ward, so we don't multiply 30 into 0.3 and give 10 mg. I would rather go low. I would give 5 mg of morphine. So it depends how you would want to start morphine, because many a times children are morphine naive. You can start even with 0.15 mg or 0.2 mg per kg as well. It works well. And you can only also think about giving breakthrough doses every hourly. Suppose if the child pain is not coming down from severe to moderate or low, then you can give another dose of single dose of morphine again. And we also use injectable 8 by 10 or 9 or 10 by 10. We go with injectable morphine according to the route. Suppose if they have IV, we give a slow IV infusion of push of morphine slowly, or we can also give a subcutaneous morphine. So it depends, the route, dosage, everything depends on patient basis. I saw one more chat thing. Currently, I have a 17-year-old who is getting weaker. She hasn't asked me directly. She has said she is comfortable with me. Always enjoys art stuff, but never asked. So anything you wanted to, I didn't get you. Was it just an experience, or you wanted to ask something else? Yeah.
So my question was actually, so should I bring up this topic with her, because she has never asked me whether I'm going to die. It's very definite. She's stage 4 rhabdomyosarcoma, and she's not going to make it. That's, I mean, her fatigue is only getting worse, right? Otherwise, other symptoms are under control. And now they have turned down IV chemotherapy, and the family has decided that she's only going to have oral chemotherapy, and they've gone home. We're going to visit them next week. But the fact is, we have never addressed the elephant in the room. As far as, I mean, that's what I think. But my query here is basically, perhaps the child, it's her way of dealing with her disease is not to know anything further about it, because probably it troubles her. And I mean, if that's the way it is, should I just leave it at that, or am I doing something wrong? So I'm always worried, am I doing something wrong? That's basically my question. I mean, with people, with children who have asked, I've always revealed, and that's okay. If they're asking you in one way or the other, and you're able to tell them, that's okay. But here, there's no question, and I'm very surprised. 17-year-old, she knows what's happening.
Many times, children wouldn't want to know, and it is perfectly fine. Even we let them, like, if they ask, we do tell, but we don't make it a point that we need to tell them that they are dying, because many times they wouldn't want to know. So we just keep that opening for the children to talk to us, either on phone. We also do this home care, which you might also be doing. Maybe you can just call her, just ask how she is. Maybe she would want to talk to you later on. So if that opening is there, I think it is pretty good what your team has achieved. Joan, ma'am, anything you want to say how it is?
I would agree with you. I wouldn't push it. If she's comfortable with you and she wants to talk about it, she will talk about it eventually. It might be that she's spoken to somebody else that we don't know about, that she has spoken to someone else. And it could be someone not even on the team. You know, we always tend to think we must talk about it in the palliative care team, but actually, sometimes I found teenagers talk to their friends. And they feel comfortable talking to their friends, but because they feel they can be open and honest and talk about the teenage feelings. So I wouldn't push it. If she's comfortable with you and she feels she wants to speak to you about it, she will. But you can always give those little opening questions. You know, is there anything bothering you? Anything you need explaining? You know, is there anything you're not quite sure of? You can give her those little openings, but don't force it, because then she will feel uncomfortable.
Thank you both.
Any other questions from any other participants? You can either unmute or you can type it in the chat.
May I just add about methadone? So we're also very comfortable using methadone in children, and yeah, we do ECG before and once in between, and find it very useful. I mean, especially when we're on escalating doses of morphine. This is just such a small amount, and thrice a day, and we're done with it. So because we don't have liquid morphine also, so we found it very useful in patients with complex pain. Just wanted to share that. Thanks.
Thank you, Dr. Meenakshi.
Yeah, in our practice, what we do is since we don't have liquid morphine, we just, because morphine is very easily dispersible, so we just mix it with water and make a solution, and we give it to children who are very small, and also children who are not able to swallow. So we can use that way also. But it is good to know that your experience also of using methadone. Yeah.
Thank you so much. Maybe I have a question to Joan, based on your experience from different countries. I mean, many a times, maybe any of my colleagues are there in the session, they might agree that we have the major challenge in getting references from pediatricians, or even from, I mean, we have a good community-based palliative care program. We do get a lot of reference for adult palliative care needs from the community. If your neighbor is unwell, they'll come and tell you, can we give palliative care to this patient? But that never happens, or very rarely happens for children. And pediatricians have a huge resistance, I might say. I think Dr. Mohammed has the advantage of being in a cancer center and in a tertiary care hospital, where we are a standalone palliative care center. A huge resistance in, I mean, we rarely get referrals. Is it, although multiple times we tell the scope of palliative care, we are actually taking away the burden of having a long-term care from them. And they don't have much to offer to the kids also. So just wanted to know how I mean, your experience in working with many countries, how to go ahead with that.
First of all, I want to say that that's a very common problem anywhere in the world, is getting those referrals going. And you can just go, what we found is that it can take years. I can remember when we started our children's hospice nearly 25 years ago, how long it took us to get referrals from the oncologists. And it was only by continuing to do good work, having doctors from other specialities saying, you know, my patients were cared for well by this hospice. But it took about 5 years before the oncologists would actually refer patients to us. Pediatricians, they're not good at letting go of their children in general, and they do pretty good palliative care anyway. So it really is building up a partnership with the pediatricians and saying to them, look, while they're in the hospital, you're doing great work, but we can help you when they get into the community. Do you want us to just pop in and see how they're doing, see if the family needs anything? We won't interfere, to make sure they know you don't interfere with the treatment that the pediatrician is going to give. What you're doing is a partnership. But what you're experiencing is, I find wherever I go in the world, we're getting this kind of problem and challenge. Where it is easier is where there's been a pediatrician who has been involved with the development of the program from the beginning. So maybe when you're developing your program, to get the pediatricians onto your board, onto your clinical team. But there are no easy answers. I think the other problem that we have with palliative care in general is that people seem to think it's about care of the dying, when in fact with children, we care for them for so much longer. And the focus really is on life and living. And wherever we are, when we talk about it, we talk about death, don't we? And yet most of the time we're actually caring for a living person who wants to interact with life. So it's also the way we present palliative care, which globally we're not doing all that well. Sorry, there are no easy answers.
I know it's not easy, but still, yeah, I think we have to wait more years patiently to get. Like, I came across one instance today morning itself that one person is on dialysis for 13 years and he cannot go for a renal transplant. But I think, but their treating doctor has not properly communicated that this cannot go on for so long. So they don't know. And if we try to communicate that, then probably that will be the end of palliative care service to that particular patient. So many a times, even if they refer, they come with high hopes, and this is just a supportive care for many of them. We may not be able to talk about the prognosis at all. Yeah, I totally understand. I think it's good to have a pediatrician in the team, as you said, developing the rapport or developing services from the beginning. Probably that might be. Yes, Dr. Mohammed, I can see your hands.
Yeah, just I wanted to share one thing, that we have been in this program for the last 3 years now in Nilofer, the tertiary care center, which I had told that there are a lot of children with non-cancer needs. So over there, we are getting around 60 referrals, 60 to 55 referrals per month. But the 60 referrals are not referrals. There are only 10 referrals that we get from the treating physicians. Even though I am a pediatrician, many a times they would be like, what additional you're going to do for this child? So at least there are a group of people who have accepted palliative care as the best possible care for a child. But there is a lot of resistance even here, the place where I work, because many times we go and search for children who are suffering from life limiting illness. For example, today we saw a child with SSPE, subacute sclerosing panencephalitis, which is fatal, and the child is not going to make it. And in the last 1 month, we have taken 2 such referrals, which we went and recognized. We did not get from the treating team. So even a condition which is definitely fatal, the child is not going to live past maybe few months, but still we are not getting that referral. So there is this resistance. I hope over a period of time, this is like we overcome it. So yes, the struggle is real. So,
Thank you, Dr. Mohammed. From what you told, I would like to take Dr. Sangeeta's question from there. So they ask you what else, what is the extra that you can give? Again, we ourselves ask the same question in non-cancer conditions or in genetic disorders. What is that extra that we can give? How effectively we can, or can we provide palliative care?
So many a times the thing is, it depends on the condition. For example, for a child with SSP, the one whom we recently saw, we can make a crisis plan where we tell the family that honest communication that the child is going to deteriorate. And if the child is developing any kind of involuntary movements for which medications haven't started, we can see that that care is provided. And in SSPE, there are multiple stages. So there is stage 1, 2, 3, 4. So if the child is in stage 3, we can tell them that the child is going to progress to a point where stage 4, where the child will become comatose, won't respond to you, will be in a vegetative state. These kind of words are not used by general pediatrician. We wouldn't tell that you wouldn't communicate with them, but we would say that by providing palliative care, we would try to give them some support whenever they go home. We try to follow them on phone. We try to make home care visits. We will take care of them in hospice, suppose there is a crisis. So having a robust program where we have home care, IP service, OP, as well as hospice helps us. But many a times, if I am a pediatrician who's not into palliative care, I'm okay to hear that the physician, whoever is coming as a palliative care physician, come and tell me that we are going to provide some amount of phone call follow, or we are there in a center where treatment options are not there. So even that amount of information would help. And if we have seen a lot of children who are having meningoencephalitic sequelae, many a times they present with neurological symptoms such as dystonia, spasticity. They present with they also present with intractable seizures as well, or neuroirritability. So all these conditions, many a times the medication is not started by the parent team. Many a times we go and start them on trihexyphenidyl. We start on clonidine whenever there are some crisis, which is where they are not able to find the source of it. For example, for central pain or neuroirritability, clonidine works. Or if there is spasticity, we tell the team that will come to the patient's bed and provide some amount of or empower the family, providing good amount of physiotherapy. So,
Dr. Mohammed, we are losing you. Dr. Mohammed, we are losing your in between. It's maybe you can switch off your video and try.
Yeah. Sorry. So what I was saying is, suppose if there's a child with spasticity, what we tell the treating team is we have a physiotherapist who will come to the patient at bedside, provide some amount of physiotherapy, also empower the family to provide good physiotherapy. So these are the so that we include ourselves in the patient's care. So that way they have accepted our care so that they can get some amount of good rehabilitation or supportive care for the child.
And perhaps I could add to it and just say to remember that palliative care is holistic care. So it's care of the child and the family as well. So often when you go in and we do that initial assessment, which is of the body, mind, and spirit of the family, of the culture, of the community, what resources are there, part of our work is actually seeing how we can support the whole unit, the family and the patient together, and not forgetting that often that spiritual care is so often forgotten. And to do a proper spiritual assessment of the family often helps them to cope with that child, because having a child, especially with a long-term condition, is exhausting. It's exhausting physically, emotionally, spiritually, financially, and the strain on the family. So having someone who understands these different elements of palliative care and who can help the family to make contact with the resources that are available, to have somebody just to talk to when it's all getting too much, can be what palliative care provides.
Thank you, both of you. There is one question on morphine. Again, what about the use of morphine in non-cancerous condition? Can be prescribed? Because usually physicians have reluctance in prescribing morphine.
So what we have seen in our practice is for conditions such as sickle cell anemia, if there is a painful crisis, it can be sudden painful bone crisis or chest crisis, we have prescribed morphine safely. And during the main period, we prescribe them. And when they're totally fine, we just stop the medication and keep them on breakthrough doses. So it depends on the kind of condition you're thinking of providing. You need to differentiate whether it is pain or whether it is neuroirritability in case of CNS conditions. We had couple of children who had hemophilia with hematoma in their knees with severe pain. In those children also, we started them initially on morphine and we slowly stopped it and sent them home on paracetamol. So whenever we have some children who are expected to have such kind of painful crisis, we see that we give them one tablet, prescribe it properly in their discharge summary and send them. So when there is severe pain, we never had any physician being against usage of morphine. And we also use some articles which tells that in this condition, morphine can be safely used. So usage of articles or study material would be helpful. because they would understand better what you're doing. Because at the end of the day, everyone wants to have the best interest of the child. So it depends on the condition, and also it depends on our assessment of it.
And one more question on drugs. Is it the 5 milligram per ml preparation of methadone used in pediatrics too?
Yeah, we use the same thing. We also have tablets available, one tablet 5 mg. And this is the same amount which we use, 1 ml equal to 5 mg. At times, it is tough to give 1 mg to a child on methadone. So what we do is we take half an ml, we dilute it, and we give it. So that's how it is. But the preparation is same, 1 ml equal to 5 mg.
Dr. Meenakshi, you had one more question. Yes, we have time. Please go ahead.
Thank you so much. So this is relating to children with hematological malignancies. Child has relapsed, is become refractory to the salvage chemotherapy, and has been started on oral metronomic therapy, and even that seems to not work anymore. And when sometimes they are brought in for supportive care, the oncologist takes the blood for sampling, and the hemoglobin is abysmally low at 5, and platelets are also dangerously low, but the child is not bleeding. So at this point, should we be transfusing the child? Because of course the hemoglobin of 5, the child is going to be fatigued. Should we be transfusing the child? Should we be actually doing investigations, or what is it? What should be the right course of action here? I mean, this confusion always comes. Why are we? Should we test or should we not test? I mean, if if the child is clearly become moribund and is clearly failing, then the matters are clear that okay, we go no further and we just provide comfort care. But when you're in this in between zone, what do you do? Like even with neuroblastomas, with bone marrow infiltration, this can happen anytime, several times in the trajectory before actually death happens. So what is the approach?
You want me to take this, Joan, ma'am? Shall I take this?
Yes, please, if you would, Mohammed.
Yeah. So the thing is, we have the same dilemma at times. Initially, when I was doing my fellowship. So the thing is, if a child has come to your center with low platelet without any bleeding, suppose the platelet is 15,000, okay, without no bleeding at all, I wouldn't transfuse. But the thing is, I won't be very rigid saying that I won't transfuse at all. If the parents are very requesting, they are asking us, please transfuse, I would want to know more what they think of the illness is the first thing. If they have totally understood, okay, this illness is not going to go away, and whatever child is suffering from, this is the most they have done. Listen to them first and then make a care plan. For example, we had a child with 10,000 counts. Parent wanted to give one transfusion for the last time. So that becomes important for the parent to be like, okay, we have given once transfusion. So we went with 2 packets of RDPs. But the thing is, we also tell them that even if we transfuse, this is not going to help the child in any which way, because the platelets are again going to fall in a couple of. Parents have this information, and if it means a lot to them to give once transfusion, we are okay to give that. But over a period of time, if they're coming particularly for transfusions, then we need to just reassess our goals of care. Suppose, since you were telling there is a child with severely low hemoglobin, and it is the child is fatigued, we also ask what the child wants. If the child wants to feel a little bit more energetic, I would go for a transfusion of whole packed red blood cells, not whole blood, packed red blood cells. So we have done that in the past, but multiple transfusions are something which we don't do at all. Whenever they ask for deliver the whole goal of care, what we are trying for the child and what is best for the child. And if the parents are insisting on giving transfusion, single transfusion, we go ahead with it. Or we also ask the child. At times, children want to just feel a little bit more energetic. So we go ahead and give once, but we do tell them regarding the risks of transfusions and subsequent transfusions. And once they are in metronomic chemo, we see that they don't come for frequent blood tests, because that itself causes a lot of distress for the child, multiple pokes, and also increases the anxiety of the parents. Till date, the number of children whom we have seen, we only had one family which were very insistent on giving blood transfusions, but even they, over a period of time, understood that this is something which is futile, and they understood and they did not ask for further transfusions. So many a times it depends on communication and also what they wish for in their child. So that's my thoughts. I have Dr. Sangeeta lifting her hand.
Yeah, Sangeeta, please.
Hi, sir. I would like to share an experience now. Last month, we had a boy, 9-year-old. He passed away in our hospital. He was diagnosed with AML. Well, his mother, father, and he had three other siblings. So yesterday we went for bereavement visit, and the family's condition was so pathetic. Like the eldest son, her elder son, and the boy who passed away, they had a very good relationship. After his demise, he has lost interest in everything. He's not talking to anyone. He's withdrawn from everybody, and the mother is worried about this child. And the other two children are like they are on their own. Mother is not able to concentrate. So after that, we had a plan, like definitely we need follow-up psychologist session with the elder sibling. And also what else can we do here, sir? Because everybody, including the father, is so upset and worried. They don't know what to do next. They are in a situation where they think the life has stopped in front of them. And they are when we went there itself, the house was in a really messy state. The boy, when he was at home, he had episodes of bleeding. So his blood is there over the wall and all that. So they haven't even cleaned it, or whenever they see all his drawings in the wall, they see the blood in that room. They are constantly getting reminded of his thoughts, and this keeps on going. So what are the possible interventions that we can do here, sir?
It must be really tough for the team to have a family suffer so much, and also very tough for the family. One thing what we do in our practice is this is not something that is guideline or something, but we see that we make multiple visits like you have done. You are planning to do again follow-up visit, which is very helpful for the family. And also at times change in place would also help a family. But before doing all those, I think having a psychologist see them, or a counselor who could talk to them in detail about what all they're going through, all this would be helpful. But the thing is, at times, even changing the place where, suppose if they're closer to your center where they can come and stay with you for a few days, even change in place would be helpful. And definitely a child specialist would be needed, psychologist I mean to say, so that we come to know about furthermore what we can do. These are my thoughts. Joan ma'am, anything else you would want to add?
Yes, I totally agree that you need professional psychological help for not only for that child, but for the whole family. Also to look and see if there's a spiritual group that they belong to that could be of help. And what we've done, which I don't know you would agree to, and the family would agree to, is that our staff has gone in and said, look, we know that this is such a sad time and it's so hard for you. But let's go through and see what you want to keep on one side for your child, and we're going to help you to clean your house. Because when you're really depressed, you haven't got the energy to do simple things like that, because the house has now become, if there's blood all over the place, it's not a very hygienic place for the family to be in. And sometimes just that gentle offer to say, come, we'll help you. We know it's just too much for you at the moment. To take the other children out, depending on the age of the children, taking them somewhere else where they can play for a while, taking them to some play therapy as well, can help. But it sounds as though each and every member of that family needs an intervention, not only the elder child, but sometimes just really practical help. I remember one of my mothers saying one of the greatest help that she had when her child was dying was a friend who came in and cleaned out her kitchen and cleaned her kitchen cupboards, and someone else who went and did the shopping. So sometimes just that practical help can also make them feel a bit better.
Thank you, ma'am. Thank you, sir. Definitely, this family needs a lot of help, and it is going to take a lot of time. But I hope they will eventually recover from this trauma. Thank you.
Thank you, Dr. Mohammed. There is another question, maybe the last one for today's session, about, I think that question is from Dr. Ariba about a patient, 17-year-old. I think it is, can you read the chat?
Yeah, I'm just seeing the chat where they have been using opioids, but it is making him drowsy or becoming dizzy all the time. Okay. So can you just tell me, like, how was the pain relief when you started him on some medications? Was his pain relief? Did you use it?
Sorry, I'm not able to hear your voice.
Hello.
Yeah.
Yeah. So, Dr. Ariba, what I was asking is, when you used medications, how much of relief did you find in this child?
Yeah, actually,
Was the boy comfortable?
yes. Initially, for a few days, like for the initial few days, he was relieved from the pain, but the pain intensity again becomes the same after like 3-4 days, and it was intermittent because he was saying that he's getting relieved from the pain like between the intervals, but when the intensity increases, so at that time no drug works for that patient, and he was also like a student, so he was feeling drowsy all the time. So that was the main issue, that we couldn't even escalate the dose of morphine. We were like that it's not helping him, so that's it was kind of a complicated case for us to deal with. Yeah.
So what I would suggest here is, you were giving him 60 mg of morphine 3 times a day, right?
Yeah, but it was not effective at all.
Yeah. So how did you reach to 60 mg? Did you slowly up the dose? Because you're telling
Yes.
it was intermittent pain, right?
Yes,
Yeah.
it was intermittent pain.
When you were,
we actually escalated it from 10 mg. Then we thought maybe it will have an effect, because he was saying that the pain used to be in the morning and at night usually. The intensity was more in the morning and at night. So we suggested him that he should take one tablet in the morning, and then in the afternoon, and one in the evening. So that's what we planned, but later on when he came back, he was again complaining of the pain, so we escalated the dose. We thought maybe it's he's not getting better, because he was not sure about it. He was saying, oh, I am getting a little better, then again he used to be like, no, it's again the pain is there, again the pain is there. So that's why we were little, and it was also affecting his studies.
Here what I would suggest, so here what I would suggest is, there is data about using neuropathic agents such as pregabalin or gabapentin. Maybe this is something which you can use in the night time, so that it doesn't affect his daily activities. Regarding morphine, I would suggest you to decrease the dose to 30 mg and only give it whenever there is pain. For example, this boy is having pain today at 9 p.m. Let him have the dose at 9 p.m. Wait for an hour. If the pain decreases, well and good. You can just keep it 30. Suppose pain doesn't decrease by 10 p.m. You can give another dose of 30 mg morphine.
Okay, but we actually tried that thing. I told you that we told him like to take it at that time also, but he was saying that at that time nothing controls the pain, like nothing works for him at that time.
Okay, I think
Because the
maybe we need to
intensity.
think beyond using morphine. Maybe we can use methadone as well. In this child, I wouldn't want to go regular 4th hourly doses because he's already feeling dizzy. Maybe he is having undue drowsiness also, which is a toxicity effect. So what I would do is I would decrease the dose to 30 and I would give him whenever there is pain, I would give a dose. And if I'm like totally sure morphine is not helping him, I would think of rotating him to some other medication apart from morphine. Maybe go for methadone, or maybe think about something that is interventional. Suppose he has any particular nerve roots or plexus that are involved, maybe try that.
Yes,
So those are few
trigeminal would.
things, maybe few things we can use. And if you're feeling, you're talking about trigeminal, where was the pain located?
It was behind the ear. It was on the back, and it was on a thigh. Like three zones were involved.
3 locations. Yeah.
Yes.
Okay. Maybe I think it will be better to decrease the dose of morphine since it is not helping him. Try some other neuropathic agents. You can try amitriptyline as well. You can maybe increase the dose of gabapentin. So gabapentin in an adult patient, you can go up till 3,600 mg dose. So you can increase over a period of time. So based on that, we can see the response. You can also get in touch with me later on regarding this child if it is not helping.
Okay.
Would appreciate that. Yeah.
That will be great, Dr. Mohammed, if you can help her to come into it. I'm so sorry that we are overshooting time by 4 minutes. I didn't want to interrupt the discussion, but if you have any other queries, please write to us. We will convey that to Dr. Gayatri's team or Dr. Mohammed, so that hopefully they'll get back to you, or we can have some kind of mentoring from their side if that is possible. Thank you so much, Joan and Dr. Mohammed, for the wonderful session. We got there are a lot of questions. I think there are a lot of questions in many everyone's mind which is unanswered or yet to ask. So please write to us if you have any more questions that you would want to ask this faculty. We'll convey that to them. Please give in your feedback in the feedback link. Thank you all the participants for the interaction and joining us for